And good evening, everyone. It's good to be back with all of you. I hope you had a good weekend and are ready to learn a bit more on our topic tonight. And well, this is week 4 of our events. I'm very, very excited to have Dr. Héctor Izquierdo with us. Hello, Dr. Héctor. How are you feeling? How are you feeling tonight?
Hello, good evening, everybody. I'm doing good, really full of energy and enthusiastic regarding this appointment for today that we have together.
We are definitely excited to have you as our presenter as well. So thank you already for agreeing to do this. I know that you are a busy doctor, but we are definitely happy that you have brought this topic to us. Sorry, as well. And as you can see, our topic for tonight is how to cope with repeated pregnancy loss. And of course, Dr. Hector will start off with his presentation, and afterwards, I think it's actually the best part for all of our patients. It will be time for your questions. So as always, please put those in the chat section, and Dr. Hector will definitely take care of them for you. Okay, so don't hesitate. And well, as you know, my IVF answers, we are here every single day from Monday to Friday to support you, to give you an opportunity to meet top fertility experts, but also coaches, fertility coaches, I mean, and of course, psychologists, anything that can help you out a little bit. And as you know, my IVF answers is a part of European Fertility Society, and we are very, very happy that we are able to bring all those topics and IVF webinars for you. And my name is Caroline. I'm your host as always. And right now, I guess we can start off with the presentation, right, Dr. Hector? Ready?
Perfect, ready to rock.
Happy to hear that then. Let's go ahead.
So, first of all, I want to apologize just shortly because the beginning, the presentation is going to be really medical and really talking to explain some factors about what are we talking about from the medical point of view. Afterwards, when we're done with the presentation, I'll be open to talk about many other factors that are really important. So, our topic for today: how to cope with repeating pregnancy loss. And that's my name, Héctor Izquierdo, that you can see it there because it's not easy to pronounce if you don't speak Spanish. So, first of all, the most important thing when we're talking about the topic is to define it. How can I recognize it? When I should think about it? It's very important. There are two topics that we need to define today. One of those is miscarriage, and the other part of it is recurrent. That recurrent miscarriage, repeated pregnancy loss. Miscarriage is every loss in the pregnancy before the week 20, and it happens in 20 to 25% of the pregnancy. Beware to this number that I'm pronouncing there. It's very important to understand that I'm talking for biochemical pregnancies. It means that one from every 4 women can have a loss in the early pregnancy without noticing or noticing. Okay? And recurrent, we say when that's happened to a patient more than 3 times. Uh, this factor here, I really love to talk about the psychological impact, how to deal with that. Some people don't know that, but I have some formation in psychotherapy techniques to approach patients, intervention techniques, and that's something really, really important in this very emotional and hard topic. Therefore, I'm very happy to speak about this topic once we go to the open run of questions. Which are the causes of the pregnancy losses? What can be wrong? Where can be the problem that makes that I don't get pregnant or I get pregnant and I lose the pregnancy? The most important of it, and that's probably the cause of 2 of every this 1 of 4 pregnancy that we spoke before, are genetical causes. We need to understand that an embryo has some code. This code is the DNA, and it works like a and a recipe for cooking. At the very beginning, the embryo makes the easy things, how to make simple things, and those indications are the complex the embryo turns with the days and then the weeks, the more it needs the information that might be in the DNA. Therefore, alteration in the DNA karyotype alterations in another way, will be the most significant factor that don't allow the embryo to have all the information it needs to develop after certain week. Therefore, pregnancy loss, miscarriaging till week 11 from itself is most of the times of a genetical cause. There are other factors that are important there, like immunological factors that we're speaking about later, infections during the pregnancy, viral infections, bacterial infections, parasites are also really important there, like toxoplasmosis, cytomegalovirus, Epstein-Barr virus, those so known from torch complex. Those are diseases that may occur in the early pregnancy and may be responsible for a miscarriage or pregnancy loss. Uh, Endometrial receptivity is also a very important factor here because an embryo coming to an environment that's not prepared for him in the wrong moment may do that the placentation, the production, the formation of the placenta in the uterus is not the perfect one, and that can make you more likely to have an abortion. There are other factors like obesity, blood sugar problems, multiple pregnancy, collagen or connective tissue problems that may make your cervix or your uterus more lax, therefore less competent to keep a pregnancy. And nevertheless important, lifestyles and stress. That's a very, very important factor we need to speak about because it's always left behind, but it's really important in this process. Uh, Type of pregnancy losses is always the same. It's the same if I lose the pregnancy in the 4th, 7th, 10th, 12th, 20th week. No, it's not the same. That's why we need to characterize them to know where are we, what's happened to me, so we can guide you medically correctly. The first topic we need to use, I'm very sorry for the people that are really up to date with some reproductive medicine societies, because the European Society for Human Reproduction does not agree anymore with this first term that we'll put in there, biochemical pregnancy, but that's the concept that we've been using for most time, that changing it might be a bit that you don't know what we're talking about. So biochemical pregnancy is for us, for the further interests, a pregnancy where you have a positive pregnancy test, but you don't get to see an embryo in the ultrasound. Therefore, this pregnancy was just biochemical, just to see in blood through the high CGM serum. The second, early miscarriage, it means a miscarriage before the 14th week of the pregnancy. Late miscarriage is after that until the limit where we think a baby is viable. And this is in every country a bit different. In the European mean, we're talking about 24th pregnancy, week of pregnancy. That means after 24th week of pregnancy is a premature delivery, and before 24th is a late miscarriage. Okay? So, what can we do? Are there some complementary tests? What do I need to test to make sure that I'm doing everything what's proper to be pregnant, to find the cause of this pregnancy loss? So, first thing can be done before it happens, guarantees or supports that it happens less, but afterwards, like when the miscarriage has already happened, really complicated. And it's karyotype. To have a look on the genetic of the embryo and then knowing if the embryo was genetically correct and therefore suitable or capable to produce a pregnancy and a live birth. What I was saying before is that something I can do with the embryo before I transfer it. That's the ideal way. In a pregnancy that's not developing properly, it's something I can test in the embryo during the pregnancy with an not invasive prenatal test, harmony test, one of those, are many brands. The second option is through an amniocentesis or a biopsy for chorion villi. These two options are more invasive and after the 10th week or 12th week of the pregnancy possible, and may allow us to know if with the pregnancy is something wrong, but the pregnancy is still developing. And the other option is, okay, I have miscarriage, then having the tissue that's been extracted from me and tested genetically. That's not always easy because it might be um, a misunderstanding or a complication there. That's if I take material from the uterus, I may as well take cells from the mother in this sample. It might be as well from confusion. Why? Because there might be a result that don't be is not going to be definitive because I may as well be seeing cells from the mother and from the baby at the same time. What can cause some confusion? Pgta, I said before, testing the embryo before we transfer them. Serologies. What serologies? Serologies is the term we doctors use to refer to test to see if there is some immunological answer to something. In this case, we're talking about HIV, hepatitis, syphilis, and other diseases that may cause early miscarriage. That's Epstein-Barr virus, cytomegalovirus, toxoplasma are causes from that, parvovirus B19. Those diseases have shown that can cause some problems in the pregnancy. Thrombophila testing, very important to talk about that. We need a perfect equilibrium, a perfect symmetry in the blood clotting system in order to have a pregnancy. How come? Because the uterus is not in the possibility of producing vessels that go direct to the embryo and transport what they need. The body produces lacunes. These lacunes, they have some spiral arteries. They come near to the endometrial lining, and then they let blood free. This blood is going to be there. If it coagulates, it won't allow the baby to take from this blood all the factors that they need, and therefore having some issues. The placenta is a very sensitive organ that can get damaged from low oxygen, low carbs, low blood sugar, and with that start dying, generating an inflammatory answer, and then producing a miscarriage as well. Therefore, if there's some procoagulation problem or anticoagulation problem by the patient, it might be an issue in order to have a pregnancy that goes to the end. There might be as well some structural damages or some structural problems in the endometrial lining that may stop you from getting pregnant. That's something easy to see with a hysterosalpingography or hysteroscopy. Both techniques are good. The gold standard, the best option is always the hysteroscopy, having a camera got inside of the uterus showing everything, but hysterosalpingography, doing an ultrasound, putting fluids in the uterus to see that everything is fine, it's been getting better and better, and therefore also a diagnostic possibility. Two important factors, RMAP in our case, and EMAP in our case, it's endometrial receptivity mapping or immunological mapping. There are two important factors, what I said before. Implantation window, very important. If an embryo comes to your endometrial lining not synchronized with the implantation window, it might be an implantation, but not a proper one. And this is going to be this embryo, make this embryo more likely to not attach properly, having problems in the production of the placenta, and therefore end up miscarrying. Immunological mapping, as we know, a woman gets pregnant with an embryo that's at least 50% not hers. What means the woman can attack this embryo, acknowledge it as a friend, as something that's not from her body, and try to reject it, like an organ that's going to be transplanted from a person that's not compatible. Solution for the genetics, as I said before, better to prevent than to cure, than always in this topic, better to do Pgt, know that the embryo is genetically correct before I transfer that, and therefore knowing that that's not going to be the cause from the miscarriage in the future. How do we do that? As you see here, we have here, wait a second. Okay, here. We have here what's going to be a blastocyst. Just here, around here. That's what's going to be the placenta, and this is the embryonal mass, what's going to be the future baby. And what we do is from this blastocyst taken from the placenta, where the embryo is less sensitive, 16 to 20 cells that I can take to the laboratory and check them if they are genetically correct. If they're so, the embryo is more likely to produce a pregnancy. Or do Pgta. When we're looking forward to do Pgta and a patient had a repeated loss, what we do is we try to obtain the most possible number of eggs. So we'll have at the end the most possible number of embryos. So we can test them genetically and at the end keep just those that are genetically healthy and capable of producing a pregnancy. That's a bit of how it works with the genetical test. The genetical test, what it does, it tells me how much amount from chromosome material is in every single line. As you see here, when we have an even amount of material, we see this line, and therefore we know the embryo genetic is correct. If there's too much material, then we see that the amount of material from this chromosome is going to be here higher, and therefore I know this patient, in this particular case, we're talking about a 13 chromosome triploidy. It means 3 times the 2 chromosomes instead of 2 chromosomes. This is some curves telling you how do we work, how much is it needed. That's what I would say. In patients under 35, they get pregnant really easily, and that's why we don't need to do PGT that much. But after 35, that's really important. Nevertheless, a factor that needs to be included in this topic is ovarian reserve. A patient who has a low ovarian reserve behaves in terms from genetical healthy embryos like a much older patient. For example, if I have a patient with 30 years old with a reduced ovarian reserve, this patient is going to be more likely to have more genetically defectious embryos than other patients. One solution for this as well, if we see that the patient is having higher rates and genetic defected embryos, it's going for the egg donation. It means we take the help from someone else who's providing us embryos from very better quality, women with good ovarian reserve, and younger women who are more likely to be genetically correct. And therefore, if we want, if needed or wanted, we can also test them genetically to assure that the chances are higher. How the egg donation program works. It's a bit of a topic that I always now want to talk about that so the patients can relate a bit to this. In Spain, the egg donation is based on 3 principles. One of those anonymity, second of them likelihood from the mother, future mother, and the egg donor. They need to be very much alike physically. And the third thing, genetically help from the embryo. We need to make some genetic matching, and as well, we need to make sure that this woman who's donated the eggs is not carrying any future genetic disease for their future babies. That's a bit how an egg donation program works. In the norm, we need a mock cycle where we see if the endometrial lining is going properly, and then a real cycle where we perform an embryo transfer. And there's a bit or cumulative pregnancy rates with the egg donation, which are really good. So some other issues that are very important is to work in what we in IVF-Spain known as friendly endometrium, as a preparing endometrium, knowing that immunologically, the implantation window, there are no malformations in order to supply those embryos we're going to produce through own eggs and IVF and a Pgta, or with egg donation, supply them a perfect womb that can accept them and let them evolve properly. This is pretty much how that with the implantation window works, and it means we need to have the perfect moment where that can happen, because if this implantation, if this formation of the placenta is not the proper one, this embryo is going to be more likely to have to end up miscarriage. That's what we say. As we know, the progesterone level changes the languages of the endometrial lining, making it more receptive or less receptive for the embryo. If a pregnancy doesn't come your time to implantate and releases HCG, the endometrial lining at the time, although progesterone is still supplied, start to decreasing and changing, and that's why the embryo is not going to adapt properly. And therefore, if the embryo comes here and start embedding the endometrium in not the proper moment, it will have enough supply to go forward. Therefore, implantation window is a precious tool to help us to have a healthy pregnancy at the end. Uh, Other factors that are very important is immunological factors of the patient's health. Immunological disease like antiphospholipid syndrome, lupus, immune reactions, rheuma, all these factors are very important to be described. Sorry, to be described in the immunological anamnesis to make sure that we're doing properly. To test the immune answer in the endometrial lining to the NK cells measure in the endometrial lining, as well as the Th1, Th2 balance, Th regulation, allow us to see if we need to make some changes in the therapy plan that would allow this patient to be pregnant and support and preserve a pregnancy. And regarding the compatibility of the HLA, what I said before, a woman is going to be pregnant with an embryo that at least is 50% not hers. Then we can make some studies to make sure if the genetical print of the father and the mother are compatible. If they don't, then apply a therapy. And if that's not successful, then replacing both of the parents, mother or father, with one that's more likely to adapt. That's what I said before about IMAP. This is that what I said from natural killer cells, Th1, Th2, and compatibility from KIR, the mother. KIR is the kill natural killer cells immunological response to the HLA type from the donor, in this case, the man. I have prepared some cases that we can discuss together or that you can see together so you have an idea how can we work with a patient, for example. So we have a 42-year-old woman with a low AMH, 2 previous pregnancies, 2 previous abortions, 2 previous IUI cycles, 3 previous IVF, not getting pregnant. The recommendation we make for her is to perform with IVF cycle with Pgta. We get to produce 2 embryos. We test them genetically. All of them are genetically unhealthy. With this, we prove that the patient is not in the capacity of producing genetically healthy embryos. Then we decide to go for the ectonation. We change this variant. We produce good quality embryos that have good genetics, test them genetically. They're safe. We transfer them. Pregnancy, healthy child. Second case, not the whole different direction. 27-year-old woman, never been pregnant, 2 IVF cycles before, embryos transfer, she doesn't get pregnant. Then, till the moment day 3 embryos were transferred, then we make a change of approach. We say, okay, we're not going to transplant anymore day 3 embryos. We're going to try to obtain day 5 embryos that are prepared for the endometrial line and put them in an endometrial line that's prepared for them. And then we make an IVF cycle, we obtain 25 eggs, produce egg blastocysts, and we get at the end 6 euploid embryos. We'll transfer one and we see she doesn't get pregnant. Then we make a test to prove if the patient is receptive with 5.5 days of progesterone, like most of the patients, and the test tells us wrong, she is not. She's a bit later, and then we make a transfer. 7 days with progesterone, not 5, and the woman gets pregnant. Here I just want to inform you a bit who we are, where are we. We're trying to have a very big group that work together, and the headquarters are in Alicante in IVF-Spain. We have in Spain 2 other clinics, one in Madrid and one in Donosti, in San Sebastian, in all of Spain. And we have also some cooperation partner, one of those in Manchester, in the United Kingdom, and the other of them we have in Germany, Baden-Baden. There are teams that work together with us and are there to help you, help us, help you. I've pretty much said everything I wanted to say, and now I'm eager to hear some questions from your side.
Wonderful. Thank you so much, Dr. Hector, for your
My
brilliant,
pleasure.
lots of details indeed. And this is never an easy topic. So thank you so much for bringing this
As
as
well.
And yes, you are very right. It is time for your questions. There's one question, but of course, if you have any, and I already see someone is typing, so of course, go ahead and type those in, and let's go ahead with the very first question. And here we have it from L. Can infection cause recurrent miscarriage?
Yes, an infection that can cause recurrent miscarriage is one of the reasons we make a biopsy as well to test the endometrial lining is a chlamydia infection. A previous chlamydia infection can produce an inflammation from the endometrial lining that would stop the woman from getting pregnant. Although this infection won't be there anymore, that what can we do? We can make a biopsy from the endometrial lining, check if some markers called CD138 or plasma cells are there higher than normally. And if that's so, then giving these patients a therapy with doxycycline 100 milligrams 2 times a day for 14 days have shown to increase the chances of a pregnancy. Other infections that can cause persistent miscarriage are toxoplasma and some viral infections. They are also treatable.
All right, thank you so much for for the first question for tonight, and of course for your help. And actually, we have another question from L. So, what is the most common problem that miscarriage patient face?
The first of them, we're going to talk about two lines. The first, the medical lines. The major problem causing women not getting pregnant or miscarrying repeatedly, it's genetical causes. The second, displaced implantation windows is also very common. Previous infection is also very common. And coagulation or immunological problems are very common. The major problem this woman uh, need to face are, first of all, frustration. There's a lot of frustration knowing that I get pregnant, I get to produce an egg, I get to have an implantation, I get to see an embryo, perhaps a heartbeat, and then I lose them. That gives this woman a sense of frustration and not being capable, of not being in the position to take care of this pregnancy. Regrets, a lot is also there, and guilt. Those are the three major psychological issues that are involved in a patient who's having repeated loss.
All right, understood. Thank you so much for yet another question and for that summary. Okay, because of course you have mentioned those things in the presentation. So thanks a lot for that as well. And okay, let's have a look. Now we will have a little bit longer question. So, do you recommend IVG? I get IVF. I'm not sure. Sorry, here, not sure.
No, it's written
IVF.
properly. If you want me, I can read it for you. Do you recommend intravenous
Perfect.
immunoglobulins for recurrent pregnancy loss? I have autoimmune hypothyroidism and previous high NK cells, but on hydroxychloroquine now, which has brought it to a normal level. Asha, you're one of those patients I was talking before when I was talking about the EMAP. Uh, all medicine, all information would be having natural killer cells missed and saying they're high and then changing the protocol. What we do now is we have a previous look in the endometrial lining and the immunology because natural killer cells are not the only one that are there. And therefore, we make a mapping from these cells without all seeing that we check what's the perfect therapy for you. And endovenous immunoglobulin is more likely for patients who have high antibodies and, for example, a lot of lymphocytes B in their blood, but NK cells alone hasn't shown any benefit with IVIG. Therefore, in this particular case, I would like to have a look in your endometrial lining immunity to make some further comments regarding this question.
All right, excellent. Thank you so much for explaining, Dr. Hector. And actually, let me go straight to the next question from Ash. Okay. So, what are your views on lit therapy, and when would you use it?
What I always recommend all patients is do not use short forms. I have no idea what's LIT. You need
Okay.
to understand I speak almost four languages and I talk them in every single then therefore I'm not always actualized with all short forms
Of
from
course.
words.
No problem. Asha, if you could just give us tips, okay? We will go back to this question. No problem. Okay? Thank you so much. And let's have a look at the next question from Maggie. Have you ever had a patient with an unexplained infertility and no doctor knew what was caused? And I'm afraid this will happen to me.
Maggie, I would like to tell you that that doesn't happen, but I'm pretty sad to tell you that we don't know everything about reproductive medicine. We're really working on that. We're researching a lot. There are a lot of people working for us in laboratories trying to find some other causes, but we're still having patients that we don't get to get pregnant. That's what I say in my statistics, that we don't have 100% success rates. There are immunological factors, there are also factors in the embryos themselves that we don't know and therefore cannot change. Uh, I will need to have more information from you to tell you if I had to think or I get to think about something I can change your previous treatments. Be, please don't be discouraged. Try to get information, but I'm sorry to confirm that there are also patients that, regardless all the help and the best medicine, we cannot make pregnant.
Understood. Again, thank you so much for that as well. Okay, let's have a look at the next question. So how does one move on from repeated pregnancy loss and have the courage to try again?
Well, the first thing, try not to look for guilty people, or at least, if so, not in the couple. Why? Because an environment at home where one of the two feels guilty, feels part of the problem, doesn't help to move forward. The second thing that's really important to do is always to look into the future, remaining in the past, remaining in the morning, and going on circles around the situation that's been traumatic doesn't help a lot. We need to learn from the past, that's very important, but we need to let it in the past and always look into the future. Uh, Try to have a support group, try to get in contact with other patients you can empathize to. You are definitely not alone, Asha. There's a lot of women going through these problems. Uh, Spaces like this one, where you get to know other people having the same problems you do, help a lot for you to understand that you're not alone. Because this loneliness, this feeling I'm not going to succeed and no one's understanding me because no one's going through my journey, it's something that's really bad. That would be my recommendation for you, Asha.
All right. Again, thank you so much. And actually, Asha has added, so we will go back to the previous question,
Yeah.
okay? All right. And let me just show you the first one. And of course, I will show you the explanation. So, what are your views on lymphocyte immunization therapy?
My answer to that is lack of studies, lack of information, lack of scientific data. The principle I don't think is false. If you ask me, is something that's been proven in other aspects. I'm going to explain for all people who was reading so we can understand a bit. So, as I said before, we said that there is the possibility from the body of a patient rejecting the embryo because it's acknowledging or seeing it as not part of the body. Therefore, one option that's possible is to take lymphocytes and prepare the endometrial lining to accept this embryo, like desensitizing the endometrial lining to allow the embryo to attach. It looks promising, but I cannot have a proper idea from that at this moment because I haven't seen studies proving that's going to be successful. There are many innovative therapies like this. We also offer, for example, patients with atrophia, with diminished answer, with refractory, with endometrial lining that are not responsive very good to an stimulation. We offer them platelets-rich plasma (PRP) in the hope that I will help them to have some better endometrial lining. That's also experimental. And for me as an expert, it's very hard, and as a man of science, it's very hard to have a point of view of something that has no scientific data supporting it.
That, of course, makes perfect sense. Thank you so much, of course, for bringing this, Asha, as well, this topic, and thank you, Dr. Hector, for your well expertise on that, and also for telling us how it works. And it means that we still need to wait a bit for more research to be done, right? There are so many of those things that we still need to wait for.
Yeah,
All
it
right.
is.
All right, thank you so much. Let's have a look at the next question, which is a bit of a longer question, okay? I had 7 negative ICSIs with one own eggs, and the first egg donation was positive. However, I had miscarriage at week 9 when only a yolk sac was visible. I take already anticoagulants, prednisolone, and intralipid infusion. I am Kirk genotype AB, so no granulocyte needed. Is there any other pharmacological treatment that I could try?
Julia, that's exactly what I'm talking about before. Until this moment, what we've been trying to do is adding medication on top of the therapy to try to make it better. And that's what's not positive. I would like to have a look directly under endometrial lining to make sure that we are not disbalancing your therapy, because most of the things you're talking about there, although they are not counterproductive, they have different effects. Therefore, I would really like to know which type of alteration from the natural killer cells in your endometrial lining you have in order to give you the perfect therapy. IVIC, Privigen, it's a brand name from IVIC, uh, might be a solution for you if there are some alterations during the lining that support that you need something like that. Otherwise, it's a very expensive medication that doesn't help anyone. So adding a medication on top of the rest just to try something else is not my thing.
All right. Again, thank you so much for your question, Dr. Hector, for your advice indeed. And Nikki has also added for older patients above 40, starting IVF treatment, would you still wait for 3 pregnancy losses before carrying out extensive testing?
Not at all. And that's a perfect question. Thank you, Nikki, thousand times. If I have 10, 12, 15 eggs in a cycle, then I can assume not testing things before I make a transfer. With a woman 40 and above, the chances of having more than one embryo are not high. Therefore, this embryo is gold and diamonds, and I'm not allowed to make a transfer before I'm perfectly sure I've done everything I have on my hands to make sure I'm transferring this beautiful, perfect embryo in an environment who's going to accept it. Therefore, for patients above 40, we need to it's my recommendation to test everything before we make a transfer. How come? Because we don't know if we're going to have a second embryo in the future. That's really important.
All right, understandable, of course. Thank you so much. And let's have a look at the next question. Do you have the list of the clinic that are in Germany that work together with your clinic?
My recommendation, Christina, would be another for you. And for all patients who have questions directly, my clinic, how we work with, where we work with, further information, where to contact me if you want an appointment with me or something like this, please write us as contact at IVF-Spain.com. I'm going to write it in the chat if I'm allowed to,
Yes, of course. Go ahead.
and then therefore you'll be able to know where can you contact us, having some information, because if Christina write us and let us know where she lives in Germany, we may as well tell her where is the perfect way to where place to go to get help, so she won't have to drive that much or to move herself that much.
Excellent. Thank you so much for putting that email address. So anyone, if you wish to get in touch with the team directly. I'm sure they will be more than happy to assist you. So go ahead. And someone is typing. Okay, so let's give it a minute and see if we have.
Very important.
Sure.
If you write an email to contact at IVF-Spain, please give some information where you get to know us. Then please, it's very important that when you write there, right? I was in the webinar for my IVF answers with
Excellent.
Dr. Izquierdo. He was speaking about this and that, and I would like to talk to him, or I would like his advice regarding this or that. This way, it's going to be easier for me to price you back and to know what I can help you or what I was speaking about. Because I make some webinars a week, and it pretty much sometimes hard to know which topic I was speaking at which moment. Therefore, it will be really helpful for me.
Of course, that's totally understandable nowadays. I mean, I do believe that many doctors, lots of webinars, lots of different topics, right? So, thank you so much for that. So, let's have a look. Next question is up. How reliable is Pgta? Despite transferring euploid embryos having normal endometrium, can Pgta normal embryos miscarry?
Pgta is very, very reliable. Perfect is non-test in non-medical aspect. There are always a false negative and false positive rate, but in Pgta is very low. Uh, it's also possible that when we transfer Euploid embryos having a normal endometrial, that we can also miscarry, because a normal endometrium is something that need to be said very careful. A good endometrial lining with perhaps no alteration in good progesterone is not everything. As I was talking before, there are many factors that also need to be taken in account.
Understandable again. Thank you, of course, so much for that. Again, someone is typing, so we need to wait. But of course, we will be slowly finishing. However, if you have any more questions, you know what to do. But also, as Dr. Hector has mentioned, you can always get in touch with the IVF-Spain team, and they will also be able to help you out. And let's have a look. We do have another question here from Julia. Can one so Pgta testing after 5-day blastocysts were already frozen, meaning the frost takes cells and freeze again?
It is possible in my clinic. And that's something that we've don't do that rare, because PGTA, as you know, is not allowed in every part of the world. Then some patient having embryos produced somewhere else decide sometimes to take it to us so we can test them genetically before we transfer them. So it's possible, and it's a recommendation in patients who have repeated failure and still have embryos somewhere else in Europe.
All right, again understood. Of course, thank you so much for that. Okay, next question is, so does DNA fragmentation in sperm take part in repeated pregnancy loss?
Not really. The DNA fragmentation, what doesn't help us is to have a blastocyst. First of all, let's go to what's DNA fragmentation. As you know, the DNA, when we see it in a karyotype, we see it as chromosomes, but that's not the way it's transported in the sperm or in the egg. In the sperm, it's just a mass of like a wall together, and then fragmentation of this means there are some part of this chain that's broken and there. If that's so, it might be some failures in the DNA that cannot be transported properly into the embryo in the future. Therefore, this embryo won't produce a non-genetically healthy embryo, but won't produce an embryo at all. And the third day, where the DNA from the sperm activate, that's going to start being problems there, a lot of fragmentation of the cells, and the blastocyst is not going to evolve properly.
Excellent. Thank you so much for explaining yet another question. And there are two questions left for now, at least. How risky is it to transfer more than one embryo with Pgta after day 5 blastocyst?
Very. And then thank you, lady, for your question. You poked out a very sensitive topic for me. Uh, if someone from you know me already from other webinars or have heard me before, you'll know that before going the way of the reproductive medicine, I was also a very long time in the fetal medicine. I was taking care of women with high risk pregnancies or issues in the pregnancy. And when you transfer Pgta tested embryo more than one in a cycle, you're having three issues. First of them, you're probably producing twin pregnancy, what's also a risk and a problem. Twins pregnancy are more likely to miscarriage. Twins pregnancy are more likely to produce other diseases like preeclampsia, gestational diabetes, hypertension in the pregnancy, early delivery, with this early delivery need of the baby of the UCIE and other problems. Therefore, we shouldn't transfer more than one genetically tested embryo. That's correct. The second factor, you've been speaking about that the whole time, and it's if it's complicated for your endometrial lining to accept and tolerate one genetical chart that's not proper, try to do it twice. Therefore, duplying the charge of genetics duplies the answer, the immunology in the endometrial lining that can produce the rejection of the two embryos. And the third factor we need to speak about that because for me is wasted embryos. Why? The increase of the success rate with transferring two Pgta tested embryos instead of one is just 5%. But in my clinic, if you transfer one Pgta embryo after the other, then you increase the chances of getting pregnant above 20%. Therefore, you're missing 15% chance of getting pregnant when you're transferring two embryos at once. Therefore, for me, Dr. Izquierdo, please don't you ever transfer a Pgta tested embryo with more than one embryo. I beg you.
All right, thank you so much indeed for that explanation. Makes perfect sense, of course. Thank you indeed. There are like two questions left, okay? So we will be again slowly finishing. If you have anything else to add, you know what to do. And the question is, how do you treat hormonal imbalance that causes miscarriage?
Well, hormonal imbalance is pretty much like saying people in the world. There are so many different hormonal imbalance that can affect pregnancy. I'm going to talk about the three major ones. The first of them, thyroids. The how do you treat it? Okay, we need a TSH on the 2 if possible, and we need to have good antibodies against thyroids. TPO, TG need to be good. First case. Second case, prolactin. A prolactin level in nanograms per deciliter higher than 9, it's less likely to get pregnant. Therefore, these patients need a therapy with cabergoline once a week before you make the transfer. Other endocrinological or hormonal factors that may affect the fertility are hormonal issues with the blood sugar process, insulin, and those factors may as well affect you from getting pregnant. And then we can treat it with metformin or other treatments that can help you with that.
Wonderful. Thank you so much for bringing those three, at least, of course. And let's have a look. That might be our final question for tonight. And the question is, so does sperm morphology or progressive motility involve, is it involved in repeated pregnancy loss?
Okay, the answer for Sarah again. Sarah, uh, other than genetical affection of the sperm itself, proven by a fish test or by a defected karyotype from the donor of sperms, being your husband or a sperm donor, the morphology, the progression, the motility, the DNA fragmentation, and the apoptosis are factors that can stop you from having blastocysts, but it's not being proved that can affect the chances of you having repeated lows.
Okay. Again, thank you so much for the explanation. And so, okay, that's an interesting question. Just give me a second. Sorry. First, Sarah, I just have put it that for you. So thank you for your answer. And the question is here. So can you sue a doctor that transfers three embryos in one transfer?
As a first of all, in this question, there are lacking information. three embryos. What type? Is it a day 2 embryo? Is it a day 3 embryo? Is it a day 5 embryo? Because these are very different things. Is it a day 5 embryo with genetic alterations? Is a day 5 embryo that's genetically tested already? And what type of patient is getting this? Is she a 20-year-old woman? Is she a 40-year-old woman? Is she a 49-year-old woman? Uh, in my personal opinion, my key to this situation is if we're making a day 3 transfer, I don't really like, but I always also do, but patients that desire to do so, that we transfer the most 2 embryos. Here we're transferring day 5 embryo, but a patient that's near to 40 and that's not genetically healthy, since we know that these embryos are not both at the same time going to be genetically healthy, you might as well transfer 2. And in the same case, let's talk about a 43-year-old woman. If she's 43-year-old and she happens to produce 3 embryos, the chances that these 3 embryos are genetically healthy are not that high. If this patient wants to avoid a second or a third transfer till she gets the genetically healthy embryo, she might as well discuss with your doctor and getting a three embryos transfer at once. I won't do that, but to say that is wrong. End of the story. We need more information there to know if that's good or right. And the last situation is, well, I believe the most important thing is how was I counseled? How was I informed? What did my doctor told me? And that's important information, because if I was informed properly, if the doctor explained me the risk and the advantages, and I make a decision, then the patient is responsible for her decision. We're not obligating no one to do something. And I think those are the three major key points to go with in to have an answer to this question.
Of course, there are many aspects to consider before, actually being able to provide the like final answer, I guess. Yeah. Thank you so much. It seems that that was our last question. So thank you everyone for all of your questions. Definitely interesting ones, and of course, Dr. Hector for answering all of all of those questions. And as you can see, there is one thank you already for from Asha. Thank you very much for a very informative talk. And yeah, some more of those are coming up. So thank you a lot indeed. It's so great to be able to be here with you, Dr. Hector, and I hope you have enjoyed this as well. It's been a brilliant session. Thank you so much. Before I let you go, anything else you would like to add?
Yeah, thank you all for your questions. Thank you, you Caroline, for this beautiful time. I think that these platforms allow me to touch a lot of patients at the same time, and I'm very thankful to be invited to sessions like this. And for the patients that are still there and heard this and didn't had the power or didn't find the inner power to answer some questions that they have, please contact us. You're not alone
Wonderful.
there. There's a lot of people trying to help you. You need to contact me. You don't need to contact someone else. You need to contact you. Please find someone you feel comfortable with and talk to your history, because the less you can have is an answer, and that's already something. That's giving you support. That's giving you company. Therefore, please don't feel alone. There's a lot of women like you expecting there, and we're here for you.
Excellent. What else can I add? But also, one more question actually has shown right here. I guess you can still answer. Are you accepting patients now?
Always. I
Great.
always,
That's
I,
great to
I,
hear.
I, I haven't denied a patient in my life. That's something I perhaps may need to learn in the future. But I'm still young and full of energy, so I find time for all of you.
So even with COVID going on, etc., you are of course having patients, always working as it should.
Yeah,
Wonderful.
platforms like this help a lot.
Definitely.
Internet, Zooms, Teams, Skype, WhatsApp. Um, that's it. That's pretty usual. And how to contact us? Very easy. Please contact@ivfspain.com. I just put it in the chat. You can look for it. And there, you're right. I was in the webinar with Dr. Izquierdo. He was speaking about this and that, and I would really like to have a chat with him. Or how can the team help me with that? Um, we work together with a big team, and I'm responsible for the international department, and that's how we work together, and we'll be pleased to help you.
That's amazing. Thank you so much indeed. And I
No
just also
matter.
want to mention that this has been recorded. So of course, you will have a chance to see this. It will be available tomorrow on our website, My IVF Answers, but also on our YouTube channel. And if you go to our Facebook and Instagram, you know that there are plenty more of the webinars coming up. And if you missed any of the previous webinars, remember that there are like over now 300 IVF webinars on our site. So plenty of useful information, I'm sure. And as you know, we will be back here tomorrow, 8 p.m. UK time. Hope you will be able to join us as well. Once more, Dr. Hector, it's been great to have you. Thank you so much, everyone.
Been
Have
a
a
pleasure.
lovely evening and take care.
Bye bye.
Bye.